Hi everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And today's guests are Avery Howler. She's Executive Director of Strategy and Partnerships at Health Gorilla, and Diana Zuskov, AVP Healthcare Strategy at LexisNexis Risk Solutions. Welcome, ladies.
Hi, thanks for having us.
Yeah, thanks so much for having us today, John.
Yeah, so excited to hear about this new partnership between Health Gorilla and LexisNexis Risk Solutions, two large organizations, kind of two different sides of the tech landscape, if you will. The platform, you have the data. So why are you coming together? Maybe you could start.
Yeah, thank you for that. So the reason that I get really excited about partnering with LexisNexis on these SDoH data points is because what Health Gorilla is trying to do is we are trying to be a one-stop shop for health data. We want you to be able to access a single API point and get whatever you need about a patient holistically. So we have made huge strides in the industry on clinical data and pulling together clinical data, and adding SDoH data was kind of a no-brainer for us. We wanted to work with Lexis because they did a lot of work to actually clinically validate their scores, and also did a lot of work to make sure that their scores and their SDoH data attributes were in line with Healthy People 2030 and other federal programs. So we're a big public-private partnership fan at Health Gorilla, and so we were excited that Lexis has the same approach.
Yeah. What would you add?
Yeah, absolutely. I mean, I think you nailed it, right? It takes data and a platform. Data on its own just isn't as meaningful unless it's together in the context of the clinical data and just the full holistic picture of the individual. So that's really what we were so excited about partnering around. And the other unique thing is LexisNexis takes thousands of sources of data and brings it all down to one individual. And so we thought, that is a really critical way to put that data in the platform and have that full 360-degree view. So I think that's why we're so excited to be working together and to be talking with you today.
Yeah, definitely. And maybe talk to us about, when it comes to meaningfully leveraging the SDoH data, what are some of those roadblocks that you think are getting in the way of organizations really driving the change with that data?
Yeah. I mean, the way I think about it is, 10, 15, 20 years ago, we were thinking about gaps in care only when the person came into the provider's office, right? We never thought about what happens before or what happens when they go home. And I think in a lot of ways, SDoH data is kind of at that same precipice. We're realizing that we need it. It just hasn't necessarily gotten to be operationalized in that context of data and analytics and understanding the full patient history. So to me, I think it's, we're right at that same point where we can look at a person's longitudinal health history, but we should also be looking at a longitudinal social care history alongside that. And so that's where that's where we are as an industry. And as to the gaps, I think a huge part of it is really figuring out where does the data go? And that's where I think, platforms like Health Gorilla really take it to that next step to integrate it with the EHR, with the care management system, really putting it in front of the right people at the right time. You want to add to that?
Yeah, I would love to add to that. So the reality is that social determinants of health have been around, and we've tried to address them as human beings forever. Religious institutions, community care organizations, they've been trying to address SDoH. What's happened over the past few decades is that the medical community is seeing where they can also step in, or where we can unite the CBOs with the medical community to really finalize and close those gaps in care. So when we're looking at roadblocks to implementing SDoH programs, a lot of what we're looking at is translating something that's been around for thousands and thousands of years, all of human history, into the current medical context. So again, like Diana said, finding where that data goes inside the, either in the workflow or inside the patient chart, the care coordination app, that's really what we're seeing as the roadblock.
Yeah.
And I think that's just one last point on that. That's so important to take home. Providers have been asking about, where do you live? Do you have, social support to help you with this diabetes medication for decades? I think now it's just about kind of operationalizing it into the workflow. And I think that's really the biggest roadblock that we need to overcome. And we're close to doing it, I think.
Yeah. Well, and it is interesting what you said, that we've had these data elements forever.
Yeah, exactly.
I'd never thought about that. That's really interesting. And that data is an important piece of the puzzle in driving the health equity and understanding that data. But what are the greatest data needs around SDoH? there's lots of data out there. Are all SDoH data created equal, or how do you look at that, the various data elements that are out there?
Yeah, so I think about SDoH data in 3 categories. One category is the zip code level data, the demographic data. That data is fantastic if you just need kind of a holistic look at one neighborhood or a zip code. Then you have data that is, I call it patient-generated data, or your needs assessments, prepare studies. And then you have third-party data, which is what we've partnered with LexisNexis around, where you're looking at identifiable attributes from public records and other data sets. And the reason that we need to think about SDoH in these different categories is there's appropriate use at different points and different kind of costs and benefits to each of these categories. So the demographic data, zip code level, great for a population, not great for understanding my particular situation. The prepare study is fantastic for understanding a particular situation, but takes a lot of time out of the clinical day to retrieve that data, and also sometimes ask patients to disclose really vulnerable information. The third-party data, obviously, as with anything, it may not give the entire picture in the way that all 3 data elements would come together, but it gives a really, really great look at an individual and a little more nuance in their situation. And I would love if you could speak to that a little bit, Diana.
Yeah, absolutely. So I think the main message to drive home is that there's no perfect data set, right? You definitely need a combination of different things. I think what's really unique about the patient level SDoH data is that you do get those insights about the individual level and the household level that you might be missing at the zip code, right? So a lot of SDoH data is very, what I would call, aggregated. And so you would think about, okay, well, here's my Medicaid population. Clearly they're low income. Well, there's nuance within that, right? There's a lot of people who maybe are commercially insured, but listen, if you lose your job or you're right at that threshold of your insurance, that you might not be able to afford the extra $50 copay for a certain medication. And so financial instability is actually a much greater, indicator and much greater driver for those folks that you wouldn't necessarily understand if you were just looking at those broad categories. So that's where I feel like the individual level is so important. The other asset that's really meaningful in a patient level data set, is also the household information. So as we think about, what really drives someone to manage their chronic conditions or to come into the provider for a regular source of care, you need that social support element, right? But you also need to recognize, how many kids do they have? Are they caring for elderly parents? Like all of these things that, again, we've known as individuals, anecdotally in our lives, like we all know that impacts. Are you going to get to that appointment? Are you going to pick up your prescriptions? But it's all about kind of operationalizing that and recognizing how significant that is in the SDoH picture. And so that's where I think there's some really unique nuances that just don't get captured if you're looking at that zip code level.
And actually, can I tell a funny story about this?
Absolutely.
Because so when we first integrated LexisNexis, I ran my risk scores. I asked the product team to run my risk scores. And it was really interesting because for certain risk scores, I actually came out how I would perceive myself, which is fairly, well off, able to get to appointments, able to complete my care plan. That's kind of where I would place myself. So if you had handed me a risk assessment, I would have said, I have no needs, I have no needs, I have no needs. But there is a particular score in the LexisNexis solution called motivation risk score. And what they really honed in on for me in that risk score was the number of times I've moved in the last several years. I'm young, I'm still moving around, I haven't landed on that permanent place. And I had to admit to myself that yes, that actually has impacted my ability to seek care. The number of times I haven't fulfilled a prescription or haven't followed up on a visit because I moved states and I needed a new primary care physician is a lot. And so I wouldn't have identified myself as somebody who needed support, and yet my social drivers of health and those risk scores that I got through LexisNexis actually made me confront the fact that I do need some extra help and some extra nudges to actually get me to my appointment and get me to fulfill my prescription.
Wow. What a great story. And I love that you highlight that my kids are actually a SDoH indicator. I'm not sure if it's a good or bad one. I guess we'll have to dive into that data, but
yeah.
No, I mean, we've talked about some of the challenges of SDoH data, right? But let's talk about some of the solutions. And maybe Avery, you could start what are some steps or some solutions out there that take SDoH from, simply data to actual action, and are there some critical steps that organizations need to take?
Yeah, so I think the number one thing that I emphasize with folks is if you're looking at implementing an SDoH program, you need to understand which piece of SDoH you would like to impact. So improving SDoH writ large doesn't exist. SDoH is a catch-all term for many, many types of factors and impacts. And so it might be more helpful to think we want to increase the number of patients who complete their care visits because we've given them transportation or because we've given financial assistance. So really understanding what tools you're going to use to evaluate and what tools you're going to use to say this was a successful program is important. That's why I like the kind of joint solution with LexisNexis and Health Gorilla so much. What the risk scores give us inside of the patient chart is this directionality. So you have the patient, you have their diagnoses, you have everything that you need to treat them, and then you also have this directional score that says, hey, their medication, they're at risk for non-adherence with medication because of this driver, and this driver. Maybe that driver is transportation. Let's hone in on that and go ahead and give them the automatic Uber credit because we have a partnership with Uber. Let's go ahead and connect them with a community-based organization, maybe a food bank that we already have a connection to because it looks like they might be food insecure. So it's really, this data layer is just integrating these pieces that a lot of medical systems have already started integrating, but they may have not had the data to automate it or make it a little more efficient. And so really we're bringing the efficiency to that system.
Yeah, I love that. I mean, and I think that's the biggest point I hear with SDoH is, okay, it's great to have the data, but how do we link it to some actions that actually improve the care? So I love those examples. Diana, maybe you could help us, think about, if you could take one SDoH seed of wisdom, right? Something that, because you live, eat, breathe, and sleep this stuff, right? You dive into this. For those that are watching, what would you leave with them to kind of help them have SDoH kind of blossom in their minds?
Yeah, absolutely. So I think the biggest thing that I would think about is, again, there's no perfect source of data. And so it's going to require us to invest in the entire spectrum of SDoH data. So we need to continue pushing on providers to be using point of care assessments. We're not trying to replace those at all. What I think there's opportunity for the data to do is to better streamline those and provide better direction into those. So instead of a provider having to ask a patient 50 questions every time they come into the visit, how do we really use the data to target the things that are going to be the most relevant to that individual? And then the contrast to that is, how do we also use the data to fill in the gaps for populations that don't regularly come into the health system, right? When we think about the underserved or people with the very complex care needs, they're the ones who have the greatest challenge to access the healthcare system. So we can't rely on that provider as what I think of as the last mile, right? We need to be, getting data on the entire population at the individual level so that we can really look at those levers, because, hey, maybe if you send someone a postcard letting them know that they can get transportation to come into the visit before they come to the visit, they're going to be more likely to actually attend. So I think there's opportunity to use the data across the spectrum, both before someone visits the provider, during the visit, and then afterwards.
Yeah. And that's what I love about third-party data. We're not putting the burden on the patient or the provider who are already overburdened. So
exactly.
Anything you'd add, Avery?
The only thing to add is just the power of the SDoH data intermingling and clinical data intermingling and other types of data, ADT data intermingling. I mean, that's what we're really after at Health Gorilla, is making those connections among disparate data sets so that the relationship between the data gives the full picture and full story of who the patient is.
Absolutely.
That's my favorite part of health IT, when two things come together and make magic, right? Like, that's when the cool stuff happens. Well, where can people go to learn more about Health Gorilla?
So healthgorilla.com. Pretty easy. We actually also have our API documentation public, so scroll down to the end of the website and check out our API docs.
Awesome. And how about LexisNexis Risk Solutions?
Absolutely. It's risk.lexisnexis.com and search for healthcare, or check us out on LinkedIn.
Awesome. I appreciate you guys taking time to share these insights and perspectives. I think SDoH is going to be key to everything going forward. So it's really helpful to learn from two experts like you. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, ladies.
Thank
Thank
you.
you.